I have great pleasure to welcome you all to this launch event for this vertical, ETHealthWorld. Now, why is ET launching a vertical, a microsite just for health? Now, there are a number of reasons. We have a website which, actually speaking, functionally is not first class. If I want to search my own story, which has appeared in the paper, which has appeared on the website, and search it on the site, it might not show up on the site. However, we have some 9.5 to 10 million unique visitors a month who come and read the news and views on the Economic Times. So we have a large number of people who use the Economic Times for their informational needs. And there are multiple ways in which you can actually leverage this advantage. One is to consolidate news on specific industry verticals, consolidate them and put them on a microsite, which facilitates interaction of the people who are involved in that particular area and create a community. We have successful verticals for telecom, ET Telecom, ET Auto. These two are doing extremely well. We have two more verticals, ET Retail and ET Energy, which are still works in progress. I'm sure ET Health will also do extremely well. Now, we are a company, just like all of you represent companies. Ultimately, the purpose of a company is to make money. However, the business in which the media and newspaper is in is to engage an audience by creating a certain kind of content, offering certain kinds of informational needs, assembling an audience, and selling access to that audience to advertisers. This is the business model. Now, there are lots of people who worry about the commercial media. The corporate media, is it actually able to discharge its duty, which earns it the name of the fourth estate of democracy? Now, these kind of aspirations are actually ridiculous. We are able to make money as a commercial organization because we serve the genuine informational needs of a democracy, of an economy, of a society, and engage the relevant audiences. Now, with this ETHealthWorld, we hope to engage all the people, professionals in the health sector, the entire range. So I was suggesting to the people who are heading this vertical that we should have some special sections which currently are not included in the site, say for ethics, so patents. These are vital issues which will actually continue to grow in importance for the Indian healthcare sector. And one more on insurance. Nowhere in the world is there a viable model of healthcare which is truly affordable, truly effective. People might say that the Canadian and British systems are functional and relatively better. They have their own shortcomings. If you need a surgery and you need to wait for 2 months till there is a vacancy in a hospital in Canada or Britain, it's not particularly good. The US scenario is litigious. They are the most expensive healthcare system in the world. And unless we are careful, we show every sign of going the US healthcare way. Our health costs are actually rising and going beyond the reach of most people. So the ideal of meeting every healthcare expenditure through a pre-pooled, prepaid system of payment, we are far away from that. And we need to work our way towards meeting this goal of making health accessible and affordable for all. So we want this site actually to bring together the healthcare community, all its different parts, the pharmaceuticals part of it, hospitals, the medical research, drug research, patents, medical devices, everything, doctors, and the commerce and business of putting all these things together and drawing the consumers to it. And this is the purpose behind creating this particular site. And I'm sure, given the wide reach we already have for our site as a whole, and the success that we have had for the telecom and auto verticals, I'm sure that this health portal also will meet that goal. I have great pleasure in welcoming you all and thanking you all for being present here. Thank you.
Thank you so very much, sir. Proceeding ahead, I would like to emphasize ETHealthWorld has been launched in association with GE Healthcare. GE Healthcare has been the main sponsor and founder for ETHealthWorld. Ladies and gentlemen, as due to certain justified reasons, Mr. Milan Rao, President and CEO, India and South Asia, GE Healthcare, and Ms. Rachna from GE are not able to showcase their presence today. Indeed, we have their video messages for you all.
To the Honorable Minister, dignitaries on the dais, and colleagues from the healthcare industry, firstly, a major congratulations on the launch of ETHealthWorld. We at GE are very proud to be sponsors and founders of the ETHealthWorld along with the Economic Times. At GE, we have got the vision of At Work for a Healthier India. As part of our vision for a healthier India, we have multiple pillars that we work on. And the pillars are primarily around distribution, around care areas, and around development of products. We've just launched a company recently called GenWorks, which is going to be focused around distribution in Tier 2 and Tier 3 areas of the country, which are going to be the areas which require the maximum amount of focus of healthcare professionals. We have a mission to launch 100 new products as part of the Make in India campaign that we launched a few years ago. And we're going to look at 3 major care areas as part of our vision, which is around cardiovascular diseases, oncology, and maternal and infant care. And the other part is on our investment and focus on care areas, where we're looking at 3 major care areas that afflict India: cardiovascular diseases, oncology, and maternal and infant care. And we're working on each of these care areas and how to provide solutions as GE for those care areas. While we work on the pillars of a healthier India, which are around access, affordability, and quality of care, one of the key things we believe is awareness. Awareness is something that is lacking in the country, and in order to solve the problems of the country, we need to have greater and greater awareness. And to us, the ETHealthWorld is a platform which enables us to provide data, to provide intimation, to provide news, to provide education about the healthcare industry that is relevant not only to all the members of the healthcare industry, but also to the public at large, also to investors, also to people who have any form of interest about the healthcare industry. We're very proud to be associated with ETHealthWorld, and I wish the ETHealthWorld a very, very great success in its endeavors. Let us together be the voice of change of healthcare in the country.
Good afternoon to all the people present here. A special afternoon to the Honorable Minister. Thank you for coming in to this event. We are, as GE, very, very proud to be the launch partner for ETHealthWorld.com, and it gives me extreme pleasure to be able to talk about GE and its objectives and the partnership with ETHealthWorld.com. GE, as you know, is one of the most innovative companies in the world, whether it comes to technology, whether it comes to the various businesses, be it energy, be it healthcare, be it aviation or transportation, or whether it's in processes and functions. As a communications function, we look at innovative methods and platforms of reaching out to our customers, to our stakeholders, to our beneficiaries, and initiate conversations that matter for tomorrow, which is relevant today, but whatever impacts the audience, the beneficiaries for tomorrow. We like to innovate and come up with different platforms. And that's why ETHealthWorld, which caters to different audience, a very strong reach, and also has different innovative ways of reaching out to the stakeholders, is what we were looking at, and that's why we chose ETHealthWorld.com. ETHealthWorld, I think when we started off, we had a lot of learning with the team. Very strong team right now. I think both the teams, be it the GE team and the ET team, got together to understand the objectives. They have a huge editorial expertise when it comes to the industry, the healthcare industry. And I think the partnership has evolved over the months. It's been 6 months that we've worked with the team, and we really feel that the team has evolved and understands our objectives and the market very well. We've, as GE, have experimented with new platforms whenever something came into existence, be it the print media, be it broadcast, or be it the digital media. Now we know that with the new government coming in place, we have a lot of focus on digital media, and the mobile penetration in India is extremely strong when it comes to the tier 2 markets or the cities beyond reach and a little far away from the metros. That's where we really want to reach to our beneficiaries, to our audience, to the hospitals, to the healthcare professionals out there. And that's why it was important for us to move into these markets through the digital media. People these days are always on the move. It's best to catch them when they are free, whenever at their own time, at different places. And that's why we chose a media which is extremely different and reaching them at their place rather than they coming to read or go to a room to see a TV. So it is actually reaching to the audience at their convenience. In terms of any innovation, there is a bit of calculated risk that one takes. And as GE, we are known to take risks in bigger, larger plays. And we did take a little bit of risk, but the risk was minimal here because it was a big brand. ET is a big brand. It is known for innovation in media and different new platforms. And then it gave us a lot of confidence there. So there was a part of risk, but the confidence on the platform and on the media house was much, much bigger. We have this audience, August gathering here with all the right, well-known people from the industry, healthcare professionals, supporting this big launch. And I think that speaks a lot about our experience and the success of this platform together. We've had a fantastic experience working with the ET team, the content team, the marketing team, the professional teams around the technical team of ETHealthWorld.com, plus the communications team at GE. We have different businesses. We've got all of them together, the global teams also, to create the relevant content for the right audience, which means that this is not only about the organization that we're working with or for the media partner. It's for the larger, bigger, healthier India. And I think it's a bigger cause that the teams are working, and it is absolutely a matter of pride for all of us to be able to work with this team.
Ladies and gentlemen, today we have with us respective dignitaries from the healthcare industry, and indeed it's a pleasure to have you all here. Further, we're going to be heading towards the panel discussion, which is on Dreaming Up a Healthy Billion, the Right Pathways for Universal Healthcare, for which I would like to welcome Mr. Rajendra Pratap Gupta, Public Policy Expert, Dr. S.D. Gupta, President IIHMR University, Mr. Girendra Bihari, India Country Director, Bill and Melinda Gates Foundation, Dr. K.K. Agarwal, Honorary Secretary General IMA, Mr. K.G. Ananthakrishnan, Vice President and Managing Director MSD India, Ms. Shobna, Executive Vice Chairperson Apollo Hospital, and due to certain unforeseen circumstances, Mr. Shivendra Mohan Singh is not able to showcase his presence, so we have Mr. Daljit Singh, President Fortis Healthcare, on his behalf. Thank you.
It's a historic moment if you see the launch of ET Health World Online. See, for many years there has been a big gap when it comes to those working in healthcare seeking timely, updated, unbiased, stakeholder neutral information. I think I believe, all of us believe, when it is ET and it's launching a platform like this, we'll have access to that information. So I think I congratulate Times Group and the people behind it for this launch and putting a very interesting topic on the launch, dreaming universal healthcare. So before I come to this topic and take on with my panelists who are who's who in healthcare, I think I'd like to democratically ask our audience, without speaking, 3 questions. This will help us set the stage of where we are today in healthcare. God forbid, if you, family or friends need to seek healthcare, how many of you would prefer to go to a private healthcare provider than a government one? Raise your hands.
That's a private or government?
Private, yeah, of course. Given the fact that we have been tracing healthcare for last so many years, how many of you feel that there is a need for tremendous overhaul of the healthcare system? And how many of you don't trust your healthcare provider or the doctor? All of you trust? That's great. I think you are all from healthcare probably.
They're not, none of them are saying it.
How many of you trust the healthcare system?
How many trust your doctors?
How many of you trust your doctors?
Half of them says no.
That's a serious question for you. We will have one question for him. So now back to the universal healthcare. See, for last 7 decades, this is not new. Those of us who read the Bohr Committee report in 1946, he talked about universal health coverage. Then came the Srivastava Committee that repeated the same. Then we had the 1983, the Alma Ata. Then we had the 10th 5-year plan, and now of late we had the 11th. 2011 we had the high level expert group coverage on healthcare, universal health coverage. So if you see the time, at the time of independence, we had 300 million people, we had the burden of communicable diseases, and we were talking of universal health coverage. 6 decades from then, we are 4 times in population. Our challenges have increased from communicable to non-communicable and communicable non-communicable diseases like AIDS. We have a serious financial issue in terms of a government. We have a tight fiscal situation. Now adding to that, it's not that we had, every time we failed to deliver universal health coverage, the beauty of Indian spirit is we came back and made bolder announcements. We still failed, we still kept on saying we'll do universal health coverage. But yes, we had success stories. The eradication of polio, stopping, reversing the growth of AIDS through NACO. And those of us who believe bureaucrats are hopeless, the government doesn't do anything, there is nothing done for the bottom of the pyramid, and technology doesn't work in rural India. We had this wonderful scheme called the Rashtriya Swasthya Bima Yojana, where a poor person can take a smart card, walk in and get a cashless treatment. Of course, it has its minuses, but it's a tremendous success. Tens of millions of people have used it. So we have positives, we have hope. Given the panel that I have, which is the best brains in the country and the people who move and shape healthcare, it's not that I'll be able to get answers for how to make this dream a reality. We will try to pick up some of the ideas, some actionable steps, the right pathways for universal health coverage. So first thing we need to do is ask my fellow panelists, is that why have we failed for the last so many years that every time we said universal health coverage, we failed. So what's your diagnosis, what's your prognosis, and what's your prescription? Starting with Dr. Gupta. It's a loaded question.
Thank you very much for posing this question to me, because I am an optimist and I am a public health professional, and I see there have been major gains in health in India. And if we talk in quantitative terms, the death rates have gone down significantly. The longevity has increased significantly in the last 6 decades. And more recently, one of the banes of India was high maternal mortality and high infant mortality. That has been reduced drastically. You'll be proud to hear this, that we have touched the Millennium Development Goals set out for India. And you have to be proud of this polio eradication. And very much, not which is an unsung story. Where is this neonatal tetanus? Do you hear about it now? Now almost 30% of the neonate deaths were due to neonatal tetanus. We don't have any. Leprosy is eliminated. I'm not saying that everything is fine. If you see the recent data of coverage with healthcare, you will see there are a lot of inequities. It's not perfect. That has happened. But this NRHM, let's see this positively. It was a path-breaking initiative, a management intervention in healthcare, where there was a change in the governance. For the first time, we came up with clear goals, what we want to do. And we set only 2 goals for ourselves to begin with, maternal mortality and infant mortality. And then, for the first time in the Indian history, we set Indian public health standards. This is under NRHM. And then, funding. It was never like this. And it was so well funded, I'm sorry to say, our system could absorb only 40% of it. That was the amount of money that was infused into the system. But NRHM has given us hopes that the systems can work, systems can deliver. And I think the question that you were asking, why coverage has been poor, or there is no universal health coverage, or it has failed, it's mainly the system's failure rather than anything else. We have technology, we have resources, we have infrastructure, but I think there's somewhere something that is happening in the system, especially the leadership, governance, and management of the systems, that has pulled us back. So I'll stop here.
Yeah. So before you say why I asked the question, last week there was a statement in the parliament that said immunization is just 65% of the targeted population. 31% of the pregnant women take iron and folic acid tablets. So if we are not even able to do that, one of the fundamental basis of launching NRHM was mother and child, where the major focus went. I mean, these 2 indicators give you enough sense that after almost 7-8 years of NRHM being launched, the folic acid intake is just 31% of pregnant mothers, and 65% of children had immunization. Adding to that, if you saw the catastrophic spending, it increased from 12 to 18% during the launch and the tenure of the NRHM. So it failed to meet its goal. So to be very clear, on a forum like ETHealthWorld, and we have all data with us, so we failed. So where do we go from here? I mean, the fact is we are still committing to universal health coverage. KGA.
Thanks, Chairman. As Dr. Gupta mentioned, I think we need to be optimistic. Because there is no way that we can give up and think that it's a failure, because I think the statistics which Dr. Gupta shared in terms of the longevity or reduction of maternal mortality or infant mortality rate, they're facts. Yes, have we achieved the goal that we wanted to achieve? May not be. There is still a lot of distance to cover, but that does not mean that we are not moving in the right direction, right? The pace at which we want to move and realize the universal healthcare probably is much slower than the pace at which we really wanted to achieve. That's where the gap is, coming in. What is heartening, is if you look at least in the last couple of elections, if you look back, there were not many elections where in the manifesto health was in the agenda. Okay, in the last at least election, health was on the agenda. Okay, that was a positive sign at least. Okay, how much is implemented, how much is the willingness to take it forward is something that we need to really work on, but at least it has come on the agenda. And if it stays on the agenda and we continue to have debates, discussion of this nature involving multi-stakeholder, discussions, because healthcare issue is not a unidimensional problem. It's a multidimensional problem and it can be solved only with multi-stakeholder involvement, both public as well as private sector. Very active involvement is required. Media, the academicians, everyone has to get involved in it, and I think we can move. As you rightly said, Rajendra, there have been several reports, right from 1946, we talked about it. And if you look at all these reports have made some very good concrete recommendations. The problem that I find is the will, skill, and the money. If this government has determined to do it, it has made it happen. And I think a classical example was polio. Polio eradication was taken up in such a manner that today we were able to achieve that goal within the time frame in which we wanted to achieve. So there was a will. We also brought in the skill. We brought in a much wider involvement of the society. You also funded it. It was multi-stakeholder approach, and we achieved success in it. So if we are able to focus, to address the healthcare challenge, it is doable. And for which what we need, I think fundamentally are two. One, as I said, skill, will, and also money, strong financial backing, but also very strong leadership. Okay, the leadership of the country must drive the healthcare agenda in this country. If the healthcare agenda gets dropped from the leadership of this country, then it will languish. If the leadership keeps pushing that we need a healthy India, because let's accept the reality, we are all talking of fantastic growth rates, 8%, 9% going to double digit economic growth, etc. Economic growth cannot happen independent of the growth in the health of the population of this country. Because we need 600 plus million population, young population, need good health. It's only that which is going to drive the economic growth of this country. And hence, we need to keep focusing on it. Do not give up. Let's not be pessimistic. Continue to be eternally optimistic. And I'm sure that we will achieve the goal. Maybe it will take a little more time, but we will get there.
Okay, I think a lot has been said, and I concur with what my friends have said. We have moved a significant way in the last 6.5 decades, over 6 decades, from a population of 33 crores, from a life expectancy of around 33 years, we have a population which is 4 times as much and a life expectancy which is double. So there has been movement, and I think we must be gracious to accept that there's been movement. Have we done a great job? Probably no, because Millennium Development Goals were set with certain time frames in mind, and I think we've fallen well short of them. Whilst we have succeeded in many of the areas, whether it's polio, eradication, malaria, a lot of work was done, great work in the area of HIV/AIDS, I think the complexity of diseases that have been prevalent, whether it's communicable diseases, and now the menace of NCDs, makes the issue far more complex, and the challenges that are coming in front of us are of a very humongous nature. I think a recent study which was spearheaded by the World Economic Forum, Harvard, and a lot of people were involved in it, they have estimated that in the next 15 years, India stands to lose about $6 trillion in terms of lost productivity just on account of NCDs. So the economic burden of NCDs on our country will be of the order of $6 trillion at today's value, which is about 3 times our entire country's GDP. And this is a function, it takes into account loss of productivity, loss of, and the expenditure that we need to incur if we don't move very, very fast. And I think the reason why this topic is there today is really to introspect as to what really didn't go well, what is it that we need to do in order to move forward. So I have a couple of thoughts on this. Why perhaps it's not gone well, Rajendra, it's really a post-mortem of what has happened. But typically, when we look at any large initiative of this nature, and healthcare is a humongous issue for our country, it is also incredibly complex. Whilst there are very high-level macro objectives which have been stated, I don't think the detailing has been done to the level to which we need to do. I mean, for every complex project, there is a project objective, there is a project plan which is actually developed. in order to implement the plan. And in order when you begin to look at the plan, you articulate what is it that you need to solve for, and what is your current state, what is going to be your future state, how are you going to actually measure the outcome of that, what is the project team that's actually going to deliver this project. And we understand that because these are projects of a very long nature, 10 years, 15 years, that people will change, but there's got to be a certain level of constancy of purpose. Targets may change. We may need to recalibrate these plans in the light of emerging challenges or new things that come out of the table. But I suspect that constancy of purpose has not been maintained on a wider platform. Yes, it's been done wherever it was felt by the government. They have demonstrated great success. I think RSBY is a fabulous example where they want to do something, it's been delivered, and it's one of the finest examples that over such a large population, we have the ability to do it, and it's been done not by the private sector, it's been done by the public sector, and I think all of us are rightfully very, very proud of it. But can we replicate this success across a wide range of issues? Today, I mean, if you really look at our own challenges in the country, I think those challenges have not gone away. If we had this debate 60 years back, it would still have been affordability, access and reliability, quality. And I think today we are talking exactly that, but perhaps on a much, much larger scale. We need to be able to articulate a vision. We need to be able to articulate the implications of the vision, and the implications are precisely in the areas that my friend has spoken about, that it's got to be around resources, it's got to be around people, it's got to be around skills, it's got to be around will, it's got to be around money. Where do we get this money from? And what is going to be the roadmap to success? Because as every year progresses, we are also adding 2 crores of people to our population, 2 crores of net new people coming in with a fresh set of problems. So the issues are huge. I don't think, in my opinion, whilst I respect whatever has happened in the last 60 years, I don't think healthcare has been a subject which has really been given the impetus due to it. We had the McKinsey report, the first credible report which actually came out almost 12, 13 years ago, which talked to the fact that our expenditure on healthcare, overall expenditure was of the order of about 5% of GDP, 5.1%. Today, we are looking at expenditure of roughly 4.8 or 4.9% of GDP. Government expenditure, which was around 1.1% of GDP at that point in time, is today, it has gone down to 0.9%. And whilst this dwindling is going on, we have come out obviously with a good audacious plan, and this is the optimism that Rajendra spoke about, that we will take it up to 2%, 2.5% and 3% by the year 2018 and 2020. How will it happen? Where is that will that the government has demonstrated in order to either create a very cogent plan, get in the best consultants, get in all the multi-stakeholders onto the table? I think there is we don't simply be working in an integrated manner. There is perhaps no think tank in the healthcare sector today. And we have stalwarts in the private sector, people like Dr. Reddy, Dr. Trehan, many others, Dr. Shetty and Dr. Agarwal, many others. Now, is there a platform which has actually been created, which brings the best from the private sector, because that's also a country resource, onto the table to solve the country's problems? We don't see that debate happening. And I think there have been great stories, Apollo, by Fortis, by Max, etc. I don't think we've tapped into the resources that are today available to this entire country onto the table. And unless that happens, I don't think we are going to get a robust plan. There will be plans which will be developed which will have several faults. There will be a lack of alignment between what the center says and what the states do. There'll be no relationship between the public sector and private sector because there's mutual suspicion, and this saga will carry on. I'm sorry to be bringing in a bit of discord here, but I think it's important for us to understand what the reality of the situation is. I think the editor said something very, very special, that we are making money, but we are making money out of doing what people want. And I think private sector or the public sector, everybody is doing their bit in order to provide healthcare. If people are paying money to the private sector, it's not happening just because they want to pay, it's because they're getting a certain outcome from there. And I think we need to recognize what we have, and we need to leverage it as a country. I think time has come for us to perhaps shake off this seemingly artificial divide which exists between the private sector and the public sector. To a person like our Prime Minister, public sector, private sector, they're all part of India. They are not outside the country. And therefore, if good capability exists in the private sector, in the public sector, put it together, get the best consultants in, get the multi-stakeholders in to come up with a plan that can be made to deliver. So I would actually submit that I think there's been more rhetoric rather than real intended action. Intention leads to hope, but it's delivery which actually builds trust. I don't think we've got there yet, and we have a long, long journey ahead of us.
Thank you, Baljeet, so much. I think you made a very interesting point on the programs and how they're built. I'll just give you a perspective that all the national programs that the government runs today, which have universal coverage, they just cover 10% of mortalities and 15% of morbidities. So if that's the universal coverage we're talking, we need to be very realistic, as Baljeet said. I think there's a very interesting point for those who are making notes, is I think we probably need to rethink, our government needs to rethink about the Healthcare Advisory Council at the level of Prime Minister, that probably gives him inputs and advice as to how to take the healthcare forward. Dr. Agarwal.
I'm going to add something is that I'm here not as KK Agarwal. I'm the collective consciousness of 2.5 lakh doctors as the Honorary Secretary General. That's what I'm representing. And once I was going to a school and there was celebrations going on, and I asked what is happening. They said we have 99% result. So there were huge celebrations. And suddenly one student got up. He says, you are saying wrong. The result is 0% as far as I am concerned, because I failed. So I, as a collective consciousness of medical fraternity, it is not acceptable, numbers are not acceptable to me. For preventable diseases, I don't want reduction. There is no way I can accept typhoid deaths. If 2.5 lakh doctors are practicing, why can't they prevent 3 lakh neonatal deaths? It is possible. Today, Pizza Group says, I have reached every corner of the house. The burger says, I have reached every corner of the country. Coke says, we are there in every corner of the country. The Election Commission says, I am there in every corner of the country. Then how come healthcare can't reach there? Now, healthcare doesn't mean, I am not talking about advanced healthcare. I'm talking about emergency and preventive healthcare. I'm only talking about preventive and emergency healthcare. Why can't it reach? I'll give you an example. Today, we did a survey of around 500 people in the city of Delhi. The awareness was less than 10%. And when I started talking about flu and dengue, 90% of them were aware. They were started teaching me, doctor, you are wrong, you don't even know this, you don't even know this. They knew much more than a doctor about dengue and flu. That means media today, whatever, it has so much power. If you can reach every corner of the house about dengue and flu, which causes much fewer deaths than tuberculosis, which causes much fewer deaths than rheumatic heart disease, I think something is wrong in our country. Our approach is wrong. If we are only going to talk numbers from 60 to 50, our goal is in 10 years we want to reduce the 60. Our goal has to be that we do not want from today any preventable death. I'm not talking about deaths are invariably going to occur, but preventable deaths, there is no way I'm looking for it. Everybody says funding is a problem. I run a program called A Perfect Health Mela every year in the city of Delhi, and 10% of my budget comes from health. 90% of my budget comes from non-health government departments. I go to transport and I say, give me fund, I want to create awareness about road safety and accidents. I go to environment and I say, I want to talk about water pollution, this pollution, that pollution. I go to skill ministry and say, I want to train paramedics. They give me funds. I go to every department I move, 90% of my budget comes from there. So if I pull down these budgets, budget is there available to me. If I want to reduce waterborne diseases, I should talk to the agriculture ministry, the water ministry, the earth ministry, the health ministry, and the funds can be generated. Then why people are dying? Why people are dying? I only want is that my patient in the country should not die of receiving a primary care and an emergency care, and that does not require, that only requires is a different approach. And if that happens, things will change. We don't want anybody in the country to die of an emergency just because he cannot afford an emergency care. Where is the fault? Private sector, government sector are fighting with each other. Private sector is going to the court that we don't want to provide that. What do you mean by emergency care? Why should we give disposables? Why should we give drugs? Fine. Government has so much money. Any doctor should be able to treat emergency care and let him bill to the government for the CGHS rates. In 2005, I was the president of Delhi Medical Association. There was a case which came to High Court. One person got a head injury. He went to Safdarjung Hospital. They says no bed. All India Institute, no bed. He went to Wellington, no bed. He went to GB Pant, no bed. Everywhere there was no bed. He went to Apollo, paid 1 lakh, got his treatment done and billed it to Delhi government. Delhi government says no. He went to High Court and the High Court directed. Because he has gone to 5 different hospitals, it was their duty to take care of him. Because they did not take care of him, they have to pay. So there is a fundamental right available for everybody that emergency care and primary care has to be provided by the government, and that is my fundamental right. And if 3 lakh doctors, if there are 2.5 lakh doctors, where is the fault? I'm not been able to understand. Why can't all the doctors sit together? Unfortunately, IMA, which is the largest medical NGO of the world, is not there in most policy makings in the government. And therefore, there is always a discount between government officials are only working for 20% of the population. 80% of the population is basically looked after by the private doctors. And in most of the national programs, private associations, except for tuberculosis, they are not there in any program.
Okay. This is good to hear. I have always been saying patients are never heard. I'll have to add doctors are also not heard.
Absolutely not.
Your turn.
I agree with all the gentlemen on the dais, and more so I think I'm going to agree with what Girish says. You've done a great job with polio, but being the sole woman on the dais, maybe I'll give you a different perspective of some of the things that I don't think that this is a problem that, you know, when we want to take on too much to say that is there a perfect solution. There's no perfect solution. There's no perfect solution of why my first child will go to Harvard and my second child will just scrape through. All these, they grow up in the same environment. You have different problems. This is a different world. But let's understand what each one has said, and each one brings a valuable perspective that you have multi-stakeholder, you need to spend the money correctly, you have to stop the debts, all that is fine. But at the end of the day, I want to, this thing, you know, we need to celebrate some things in life. And I think in your opening, you made something that kind of really made me feel, you know, 2 things which I feel that we really need to change in this country, and I'm so happy that you're doing this, that ET is doing this, but we have to do it also for the right reasons. We continue to put back and say that health is a subject that should come free. Why is that? It's not necessary that health is a right of everyone and it should be given free. This is a country, or I mean everywhere in the world, I think what's important is that it's the right of a citizen to be able to get a good quality of air. To get Swachh Bharat is a right. Swasth Bharat requires some amount of help with that you might have to pay for it. And just before coming here, I got a phone call from my father, Dr. Reddy, and he said, you know, it's such a red letter day for us. We did 22 organ transplants in one day. Nowhere in the world. Tell me, if this is a failed system, we're sitting on the dais talking about a failed system, can you do 22 organ transplants in one hospital, Chennai? We did 5 liver back to back. No one in the world can do that, especially in a failed system. And especially, who can afford it then, you say? Why should it be free? India, lowest cost of medicine in the world. Anant will tell you, with this highest sales in the world, with that, the heads of GSK and MSD and everyone should be sitting here. But because the price is so low in terms of quantity, but because the price is so low, why will they sit here? They'll sit in the countries where they make more. Same thing. Why are we sitting here in India? Lowest cost. It has not been increasing. When we started Apollo, it was $2,000, the cost of an open heart surgery. People can still perform an open heart at this price. And when is that? 30 years. What kind of inflation is that? You know, there's zero inflation. I can argue back with you. This is the lowest cost in the world of medical care. With that, celebrate it. The stuff that we do, it's only the amount of people. And Daljit spoke about NCDs. I do agree. This is a triple gold medal. We'll lose 6 trillion. Where do we have 6 trillion in lost income to be able to spend? We don't have it in India. Our GDP is 2 trillion with that, and it's not going to happen. So there's the thing that I want everyone to take back, that health is a very personal thing. But what they don't realize is that sometimes among ourselves, we trivialize life with that. Oh, 7,000 people died, 300 people died, this was there. Do you know the cost of a person? Somebody actually put a price tag on it, and we did some research. A Yale professor said the cost of a human is 60 trillion. I mean, that enough zeros that will go from there to there. That's the price of a human life. But when it comes to us, your car has to go on that 15,000 kilometers, it has to go for servicing. People don't get a checkup. So we can prevent these things, what you talk about. These things, cancers, heart disease, diabetes, all these, it's cheap, it's free. And suddenly I started hearing when I was in the government and moving around those circles, they had started saying, we'll give it free to every citizen. What happens with this thing? They take the onus. You'll all have to leave the country. If they're going to give free medicines to every single person, they're saying for NCDs, they have these plans. And I know RSPY is fantastic, but do you know how much RSPY costs? It's a no-sum game. People are taking money out of your pocket, out of taxpayers' money, and the insurance companies are giving it at below a price. At 400 rupees, at 300 rupees, we fight. I run an insurance company, so I'm not too. I love the program. I love Arogya Shri. I love Yashashwini. Huge programs. India can actually deliver if it does it right, if it gets the quantities right. So I'm a great believer. Please don't get me wrong, I'm an optimist. So I want to close on an optimistic, saying that we're a fantastic country. The thing is that we need to value ourselves a little more. We need to have that little faith in doctors, and we have to have a different mindset. Pay for a great service. Pay for it. Pay world class. Do this. Allow India to flourish. Allow India's best doctors to stay in India rather than be in a Mayo or be in a MD Anderson. Let them come here. Let them not run the NHS system. Let them come back to India and let them be here with us with this. Let us celebrate wonderful systems like Ananya, like polio eradication, what they're doing, large scale. Swasth Bharat is so important because that's, that Swachh Bharat can and is the only solution when we have great drinking, when nutrition problems are taken care of, air quality, so many of these will go away. On top of that, I encourage people to move. Let the government give free checkups. Let us figure out what those are with that. So I think that these are the wonderful things we have. The things that frustrate many of us private players on this table is CGHS and those rates. And people really drive these rates down. But that's a subject, that's another subject. And we have to understand, so it has to become, if there's one thing I would want this country and what will allow this 80% to grow and this thing, regulate it properly, but do not denigrate it. Don't say, why shouldn't it be done free? Why are you profiteering? All these should go away. It should be a different language. It should celebrate excellence. And that's, I feel, then we come to a universal approach, because a universal approach really needs the universe, not just one person, not just one subset, that we're not just playing to people in rural areas, people in this thing, and we get lots of those. We want to really say what's best for every Indian, and every Indian is different. So let's understand, let's celebrate, and first let's take charge.
Thanks, Shobna. You bring an interesting perspective. One is on the cost of life. I read in America they value the cost of life at $6 billion US. See, I don't know how you get million, not trillion. So
the price is $1 trillion.
They talk everything in trillion.
Yeah, but the Yale professor actually put a price on it.
So what the point I'm making is, see, we cannot create a life. So we really cannot attribute a monetary cost to it. But I think we can save a life. What Dr. K.K. Agarwal said. Giren, over to you.
But I just want to add, she talked about why should we provide free care. Free care is basically only for emergency care.
We'll come to that. We have a next question.
I never said why.
No,
but there's a right. People do need free.
We'll talk about that.
The
next question is
that. Okay. Emergency care. Suppose I get an accident, and I am here in a particular place, no money and no identity. And if I don't get a free treatment, I will die. Otherwise, I could.
So we'll talk about the next one. We'll talk
but
about.
actually, the
Let's
government
start.
really has done something for that.
Let's not that bring that. Yeah.
That accident insurance. That's happening throughout India. Sorry.
I think we'll come back to that question.
Yes, we have a question.
So first, thanks for having me here, and my best wishes to the ETHealthWorld.com initiative, which I think is going to be great. I'll just take a second just to say what we do, because we are a bit different from the players here, and then I'll answer to my best the question you've asked. So our focus is really on the narrower spectrum of health, both geographically and in terms of what we do. So geographically, we've chosen to work in UP and Bihar, and that's with the majority of our efforts are those two geographies for obvious reasons. And the two of them together is the population of the US. UP is bigger than Brazil, and Bihar is bigger than Mexico. So we feel like our focus in those two geographies is more than enough to keep us occupied for a while to come. Also chosen to work on that spectrum of maternal, neonatal, child health and reproductive health, where we feel the inequities are still quite staggering. And even though India is migrating to NCDs and so on, there's a huge inequity linked to those population groups that we think we need to focus on. And the other part of the work we do in health is on select infectious diseases, for example, polio, which we have been involved in, but also other things that feel like very 19th century diseases like Kala Azar in Bihar and so on, which are truly things that can be actually gotten rid of pretty cheaply and pretty fast. So this is the universe we look at, and therefore our perspective on some of the healthcare issues is perhaps narrower than many of my counterparts here. Nonetheless, I'll attempt to answer your question from my perspective of why has this universal health coverage not come to fruition despite repeated plans, repeated attempts to say we need to go from our current between 0.9 and 1.1% of GDP to 2.5, 1.85. We've heard different numbers. And I think there's three things to it. One is, it's very current. If you look at the UK, elections are tomorrow, day after tomorrow. NHS is one of the three biggest topics of health of the electoral debate in the UK. In the US, similarly, in 2016, I anticipate Obamacare will be one of the major topics of electoral, why you win and lose an election. In India, that's not going to happen. It hasn't happened. Nobody has lost or won an election over health. It has been now, as you were saying earlier, in the manifesto, but honestly, the government in anywhere in UP or in anywhere in India has lost the election. And it has to do, I think, with the fact that there is no actually public outcry for health that is organized. And I think it has to do, in my perspective, from the fact that the middle class, which is the influential part of the electoral debate, has in some respect exited the healthcare system that's public and doesn't have a stake in it. You can get pretty cheap care. You can get on your own. You can go to the pharmacy and get pretty cheap drugs. You're not vested in the public health system. You're not vested in whether or not the public healthcare system is delivering its full capability or not. I think there's no voice that actually is pushing that to happen. Therefore, the political side of things, which is very responsive to the public, is therefore not seeing that as a top priority for itself. So I think that's one element of the public not being invested in it. And I think any future attempts of addressing universal health coverage needs to bring the middle class back into the picture somehow, which I don't think is the case today. The second one is when we talk to the center, there's people like us who advocate for health, and there's people who are sitting on the other side of saying, okay, you're lobbying me for putting more money in health. Let me tell you the 5 reasons why I disbelieve you. And the first reason is, I gave you money last year, you couldn't spend it. That's the argument you hear first from the Ministry of Finance. And this is why you get the 20% cut. Come back to me after you actually are able to spend the money that you are able to, I gave you last time. Second, I gave you money, but I don't know what happened to this money. I'm looking at Nepal, which is half as rich as India, or Bangladesh, which is very much poorer than India, and their life expectancy is 68 years and 70 years. The IMR, the MMR is better than India. So, and then you come to me every 10 years with your NFHS survey and telling me what has happened 10 years in. So I don't get a feedback loop about the performance of the healthcare system that gives me confidence as their exchequer that my money is well placed. I think the second challenge we get. The third one is a more fundamental one, which is about what is the role of government in health. I think there's areas of complete agreement and I guess complete disagreement at this point. The areas of complete agreement are the ones we all like: public health, which are pure public goods or quasi pure public goods, like vaccination. There's no question that government needs to drive this agenda. It needs to do an excellent job of it. It needs to do better than 70% coverage. By the way, the data that we have on vaccines is very obsolete, so it has actually gone quite a bit higher than the 65% you were mentioning earlier. But the government needs to do a good job of this. It needs to be funding it and needs to be providing it probably as well for the majority. But then you move to grayer areas where India doesn't have a consensus. What is the role of government in fixing what economists would call insurance failures? And how do you given that people would prefer to choose, people who choose insurance who are sicker, etc., the whole adverse selection, moral hazard question. What is the role of government vis-a-vis that? An even bigger question is the one that Shobana was mentioning a minute ago, which is the role of government in equity in health. Do we think of health as any other good? So if I'm rich, I can buy a Mercedes. If I'm poor, I go on a bike. That's fine. Society accepts that. But it accepts the fact that poor kids die and rich kids don't die. And if not, that's not an argument of public good, it's an argument about equity. And what is the sense of equity we need to bring? And therefore, what is the role of government in funding, not at the point of care, which is a different question, but for healthcare vis-a-vis other forms of payment, which can be all the way to out-of-pocket payment, which is the case right today. Then there's a fourth question that comes in, is like, okay, you've persuaded me that health is a good thing, I need to be going after it. What is the right expansion path for health? This is the big debate, right? Do we go public? Do we go private? Do we go, what mix of funding and provision of public and private? People disagree fundamentally about these issues. One camp will say the government system is so broken, the government failure is so bad that I'd rather work with the private sector because I believe I can fix whatever failures there better than I can fix the government failure. And the other side believes the opposite, which is, those horrible private sector people will out to make a buck on me. I'd rather trust my own people and try to fix the public care system rather than have anything to do with them, right? That's a bit the caricature on the both sides. And I think we need to bring that conversation a bit closer. And similarly, how do you architect the healthcare system if you were to expand it? Public-private is one dimension of it. The other one is how do you bring together primary care, preventive care with secondary care, tertiary care, which is three very different kind of segments of the system which need to work together much better. And the fifth question I hear a lot from the center is, fine, you've persuaded me that health is a good thing, there's a way forward that makes sense to me. Where's the money going to come from? I'm fiscally tight. I'm in an environment where I don't have this kind of money. Where does this money need to come from? And there again, we have not been very creative in terms of finding so right now we've defaulted to out-of-pocket spending, a little bit of insurance at the margin, and then a large majority of people who just pay out of pocket. So how do we, other ways in which we can co-opt that funding that exists today? For every $1 government puts, people are putting $3. And how do we leverage that spending that's happening today in a different way than we're doing today? So I think unless we address these questions at the center and any attempt of policy and so on, if you don't address those issues, we'll find ourselves in 10 years from now repeating some of the same conversations. I'll end with one last point, which is, and we forget this, that states, if you look at the way health spending is in India, you would say about 7% of it is central government, 14% is state government, 78% of which is out of pocket, and the balance of it is people like us, with a very, very small group of people who are at the fringe of it. But it's a state subject. States are 2/3 of public spending in health, and yet we don't engage them. There's an assumption they will follow through, or they need to be persuaded equally as much as the center, given that they're actually the exchequer for health for the most part. And if you look at the data on how of 100 rupees that any government or a state government has, how much they spend on health, it's anywhere between 3 and 5 rupees of 100 rupees. So they're not persuaded themselves that health is a good buy. And as we have the 14th Finance Commission pushing more money to the states, I think it will become even more important for us to engage at the state level, the think tanks and so on that people are talking about, to have that kind of dialogue at the state level equally as much as at a central level. So
thanks, Chris. One of the questions out of these reasons that we talked about, still being an optimist, why probably we kind of failed. If there were 3 things that we were to bucket, is it the failure of leadership? Is the issue of finances? Is the issue of execution? Which you would rate at the top? Just one: leadership, financing, or execution?
If I have to answer only in one word, is this execution?
Okay.
It's governance.
Okay, that's leadership.
That's leadership.
Leadership, clearly.
Yeah.
Leadership and execution both are connected.
Yeah,
leadership, execution, and
Finance.
finance. Yeah, I think it's more of execution.
Okay, great.
I'll take a pass.
Okay, thank you. So majority say, let me, we just, it's essentially, when we look at the discussions I've been having, leadership is sensitive to things, rest probably things will fall in place. But now we'll move to the next question. Before I go to the next question, I would like you to answer one thing. If there was quality healthcare available in this country, if you were in a position to pay, how many of you would pay for it? Raise your hands. Good. So, like Dr. K.K. Rawal said,
What are you saying?
Everybody.
There is
There is
quality healthcare. How many of you are willing to pay for
Yeah,
it?
yeah, that's
Rather than if there is.
no, if there is, because the question is of quality.
So, Daljit and I are taking offense to
Yeah.
that. And
Don't
Dr. Agarwal.
We will catch him outside.
Yeah,
Yeah,
we'll catch him
most
outside.
welcome. So,
I think we need to answer the question raised by Daljit and Shobna about the private sector.
We
The
will come to that.
relationship of
We'll
private
come to that.
sector with the government.
We'll
That's
come to
a
that.
very, very important question.
We have time
We
permitting.
need to
we'll get it.
realize that private sector has a very important
It has,
role
yes.
and has a major role
Yeah.
up till now.
Yeah.
If you look at the statistics, the way the private sector has contributed.
We'll come to that, Dr. Gupta. So, Dr. K.K. Agrawal said it is unacceptable to have preventable deaths. And on one side, we are talking of universal health coverage, which we are talking highest possible standards of health, irrespective of the ability to pay. Given the fact that people who have ability to pay are willing to pay. So, how do we define universal health coverage? Is it all for all the health, free to all, or where it comes? Like I said, emergency should be free. Emergency care should be free. So, Dr. Gupta, how do we define universal health coverage in this scheme of things, knowing that India is in a very complex situation? You have probably 110 million people who are senior citizens. You have children where you need to be focusing. You have 700 million people who cannot probably pay. So, where do we start in universal health coverage? What is a pragmatic approach towards it?
I think this issue of universal health coverage came up because the healthcare was not accessible to the people and not available. They were not able to avail, maybe for social reasons or for geographic reasons or for financial reasons, maybe. So, how this universal health coverage, the usual way it is defined is the equitable access and availability of affordable quality care to all citizens, all people, rich or poor, urban or rural, or whatever segment they are in. It is accessible to them and which is affordable and of high quality. So, that means that people, this inequity has to be taken care of. That is a sort of a social issue, a social justice issue. This equity is a social justice issue. Why people should not have access to care. Forget about ability to pay for it. Somebody will pay. Somebody was asking me a question one day. Who is responsible for health? It was very difficult to answer who is responsible for health, individual or the government or who. Then he simplified the question, who produces food grain? The farmer produces food grain. Then he said, so the government doesn't produce food grain. It's the farmer who produces food grain. I think what she said, it is the responsibility of the individuals and households and families to take care of their health. Government can provide care, can create a system, but to access health care and utilize health care, we have a major issue of poor utilization of health care in the system.
My question is, should it be free for all, or should it be based on the ability to pay? Because that changes the entire equation of how much can you finance.
We are trying and struggling to answer this question for last 60 years.
No, but there has to be
whether the services should be free.
Yeah, because you have to
because
understand that
the
it's
fear
not
is this: when it is free, people don't bother about it, don't
overly
value
free.
it, and when you don't make it free, maybe the issue of inequity comes in. So I think this free should be reserved to those who are not able to afford.
Fantastic.
See, in my opinion, if you are talking about accessibility of to the infrastructure for getting the necessary redressal to the healthcare issue, availability of appropriate treatment, and affordable. The moment we are talking about affordable, it's depending on the economic status of the individual, right? If there is a poor person where affordability is a challenge, I think it is the government's responsibility to ensure that the below poverty line or sections of society where there's a challenge, government chips in and does provide the health care free of cost or at a very subsidized rate. But when it comes to sections of society where affordability varies from different sections, because India has all sections, and so it can be, you pay for the type of service that you want. And in fact, that's where if you look at some of the reports that we referred to earlier on, I think it's been pretty well articulated. They said, listen, give a basic level of service, primary care, healthcare service to the population that is required to address the basic needs, and people who cannot afford, give it free. And then if people can afford and want to top it up with additional, comforts or facilities or sophistication, so be it that individual pays for that additional quality of service which he or she needs. I think that's the only way. So that's the reason why we are talking about equitable. We are not talking equal, right? So and that's the way it is. In a country like India, I think we must have both free medication for those people who need it and who deserve it, and for those who can afford, I think they must be charged, they must pay for it, and probably that's also a system which cross-subsidizes to some extent the have-nots in the society. That can be a good model to create.
Thanks, Ilya. Because Dr. Agarwal has to leave, I'll give him a chance.
I'll just, now I'm speaking as K.K. Agarwal, not as Dr. K.K. Agarwal.
That's
K.K.
diplomatic.
Agarwal, that means Dr. K.K. Agarwal as a patient. Even if I become a patient, I become a K.K. Agarwal. So from patient's perspective, what do I need? I need safety. I need a safe, whatever treatment is given to me, I need safety. I know safety comes at a price. I'm willing to pay for that. I need a quality. But quality doesn't mean that my work can run with Maruti, then I don't need a Mercedes. I need a minimum quality at a minimum, whatever is necessity for me. I want affordability. It should be affordable to me. And I'll give you an example. IMA recently did a survey, and we went to a pharmacy, and we picked up a medicine called meropenem. And meropenem is given thrice a day, 3 grams dose for 10 days. So the same pharmacy, I took up 10 top companies of pharmaceutical companies. It was available at 600 rupees, and the same medicine was available at 2,800 rupees. With the same chemist, same pharmacy, same hospital, top 10 brands of the country. One medicine is costing 600, another is costing 2,800. I calculated the cost difference. The cost difference was 60,000 rupees. That means same hospital, same people working in the same ICU. In one patient, it is billed for 60,000 less. Another patient, it is billed for 60,000. It is not acceptable to me. It is not acceptable to me when I go for a stenting. If CGHS says, CGHS for me is because CGHS treatment is for the Prime Minister and for the President. Because if Prime Minister and President, if they go for a treatment, they are supposed to get a CGHS, they are entitled for CGHS treatment. If CGHS says that a stent costing 20,000, whatever, if they say this stent is approved, then for me, that is a gold standard. And if that is a gold standard, then I need to promote that, to come out with a Make in India concept. Why should I be offered a stent which is costing 1 lakh or 2 lakhs by a Mediclaim company? Mediclaim should only reimburse what is applicable necessity, minimum necessity. That is how the public insurance system should cover. That is how the government should cover. That is how the public sector should cover. I have to add only one line is, just because I cannot afford, I should not be denied an emergency care. I'm adding to everybody. I'm not saying give me free, but at that particular moment, I may not be able to afford a particular treatment on that particular moment. At that particular moment, I may not have money. I may end up into a crisis. I should not be denied of an emergency care, because under the Article 21 in the Constitution, I have a right to live with dignity. There it is the state responsibility to give me a free treatment. I am not, in any way government is not giving a free treatment to 80% of the private sector. They are only giving it to the 20% of the government sector. We are going to the government hospital. So nobody is expecting a free treatment, but I have a right to receive emergency care free of cost at that particular moment if I cannot afford. 2, I do not want unnecessary, non-transparent price variations, where for the same treatment, I can be billed for a lakh and I can be billed for 20,000 rupees. Just because Mediclaim is paying me, my bill is more. Mediclaim is not paying me, my bill is different. Public sector is giving me for the same bill, the bill is 50,000 higher. It's not acceptable to me as KK Agarwal.
Sorry, can I just chip in? Okay.
Absolutely. Absolutely.
And I agree with you about equitable. Don't think I'm not talking about equitable, but I just want to chip in with one thing. People who want to drive this thing, the people who want to drive a Mercedes should not be stopped from doing so in this country. We are a democracy. So let me make that very clear. And coming to stents, I think is very important for us to realize. Let CGHS put a cap at 20,000 rupees for the stent that they want, but let me tell you, the President of India will not use that stent. He will use a dissolving stent, and so the IP on that stent today, it costs 1,50,000. But the thing, and I agree, if Dr. Agarwal wants to use it, maybe he'd want to use it. But if he's that 2% where the stent will collapse, like he said, he's the 100, the one who failed with that. And that's the reason why people give you. It's the same thing. Anant, I'm sure, was squirming about the meropenem. With that, it's there. You can buy a generic version for 1/100th the cost. No,
I'm talking about top 10 companies.
Top 10 companies, even then. So but the thing is that people who have got the IP behind it, that's what they do. And I'll tell you, even in our hospital, in the ICU, whatever a doctor writes, we will use that, because it's an ICU situation. But when he comes to the room, then we ask the doctor, can we substitute? And then we bring a cheaper alternative to the patient. So these are all choices that a doctor and only a doctor can give you. And medicine is not about a black and white situation. It will be about choices. And when you talk about equity, I will never say no. That you brought it out beautifully, Girish. You all brought it out, Doctor. You know, about equity and how everyone deserves it. How we get to the equity is really the execution challenge, the leadership challenge, whatever you said. But at the end of the day, I'm telling you, there are choices. You know, the scarier version of this, and why we all think CGHS believes a doctor's fee, you should be objecting to CGHS. How much is a doctor's fee?
Less than 150.
150 rupees. That's, you pay your driver more than that every day. And this is what you want to pay a doctor who's actually spent this much money studying. So it is a skewed scheme. And they will not use many of these things. So I think that that's
Shuna will come to that
caution.
very interesting point.
But I answered my question on that.
Yeah, thank you.
Debatable.
I think the issue around pricing is always very emotive.
Yeah, we'll come to that. You know, the whole idea is what do we put under UHC?
Yeah. So my personal view is that whenever you're putting universal health care, we've got to put certain minimum requirements, and that minimum is what needs to be conformed to. You know, I was just doing a very rough calculation, Rajendra, and there are many experts sitting in this room, just to get an insurance for an individual, forget a family of let's say 4 people, you probably spend 8,000 rupees or 10,000 rupees, which covers you for 3 lakhs per year. We've got a population of 1.3 billion people. Spend that 3,000 or 2,000 rupees per person and buy insurance for everybody. I'm just talking a theoretical concept. Okay, 2,000 into 1.3 billion is equal to roughly 300,000 crores of rupees. Okay, and in 3,000 crores of rupees, you actually cover the entire population of the country, and that expenditure is less than what the entire healthcare sector today is spending, which is close to 400,000 crores. Okay, now the fact is that there are models which can be made to work. So why should I, as a government or as an administrator of a country, want to get into all this complexity when models exist today? I mean, that and it's not necessarily that expensive. That's number one. Number two is that, and I entirely agree, when there's an emergency requirement, everybody, and I think most right-thinking hospitals will take care of emergencies. Nobody refuses emergencies. But I think the point that we need to understand is that emergency care doesn't come free, and there needs to be an equitable system of dealing with it. And if government is the regulator for that, then we need to make sure that there is a reimbursement mechanism for it, to make sure that those who are inclined not to accept such patients also accept it. Because in the private sector, you have nobody bailing you out. There's nobody paying your delta costs. We cannot subsidize stuff, because what we generate is what we pump back. And yes, there's an extra that is made. The extra is distributed to people who have invested in that enterprise. And I think we need to look at it from that point of view.
Yeah, excellent. Great, you.
So you asked a couple of questions. Let me try to get back to them. So one of them has to do with universal health coverage. And what it means, the definition, how do you get there, and so on. And I think healthcare systems actually have two very different objectives. And you can achieve the first one and not the other one, and vice versa. The first one is health. And I think we kind of forget that, but actually health outcomes are an important piece of how you do that. And it so happens that a lot of the public health work that we do, which is pretty cheap, gets you disproportionate health outcomes. So you can save many kids by providing the right vaccinations for pneumonia, diarrhea. And if you look at the pie chart of kids under 5 who die in India, a good 40% of that is vaccine preventable, very, very cheaply. The other objective, though, is financial protection, which is very different. So it says, if you can give a cancer drug for somebody in the last stage of life that gives them 3 more months of life, that's very expensive. And does that person have to pay for this or not? That's a completely different objective. So I would hope that as we look at universal health coverage in India, that the second objective, which has more of an attractiveness from the point of view of the consumer, because the first one is invisible. My kid didn't die because of a disease they never got from a vaccine that I don't quite understand. It's not very attractive, so I'm not looking at that as my dominant part. So, but as policymakers, I think we need to make sure that that element of primary care, public health, remains a big part of whatever construct we have of universal health coverage. That's one piece of this. The other one, you asked a question of healthcare being free, et cetera, et cetera. I don't think there's such a thing as free healthcare. I mean, the question is like, how do you pay for it? And I think when we're asking the question, how do you pay for it, this is what can spills over about people paying for it, not paying for it at point of care. So let me distinguish those two questions. At point of care, which means I'm sick, I go to the doctor, does it make a difference for me? Does it make a difference if I have to pay something or not? I think that in India, especially the BPL population, is so price elastic that even a small amount of money you ask them to pay at point of care is disruptive, causes them to move away. And we have abundant examples of why that happens and how this happens. And you can see the data on JSY of how a small amount of money caused people to come back in droves to public hospitals, which is not very good, but it tells you a little bit about how price elastic people are. So having people to pay out of pocket at point of care is not a very good idea. We can discuss. Now, the other bigger question is like, how do you pay for care, and with this emergency care or not? I think the spectrums are very known. They're canonical around the world, right? Out-of-pocket payment, which is what India does for the most part, private insurance, social insurance, and then government tax revenues. These are like basically you have some variations here in the medical accounts and community health insurance, but these are basically the 4 methods by which you can pay for healthcare. When you say it's free for you, you're saying implicitly that somebody else is paying for it through the back end of social insurance or taxation regime. And you can look at those 4 ways of funding healthcare, and they have merits and demerits in all of them. Clearly, from the point of view of equity and progressiveness, government taxation is probably the best one. But very few countries actually have a system that's based on government. Most of them have some mix of social insurance and taxation system. And then you have the worst one, which is out-of-pocket plus private insurance from the equity perspective.
But Greg,
the efficiency perspective
was very specific in terms of which services, like it was a very strong view that for emergency care services, you need to have a pick and payment mechanism. A person getting into emergency care shouldn't be asked for money at that point in time. Very reasonable to look at. The other was those who can't afford to pay should be free, but those who can afford to should either be subsidized or probably they should pay, or probably they should do a top up on the basic services. So that's something that you concur with, or you have a different view.
How you get to it is this
thing.
And
you concur. Fantastic. So seeing that we have less time, it is an interesting question to look at is, under universal health coverage, do we have pay for services, or we look at a model called the health management model, where you give capitation for a certain segment of population to a healthcare service provider and say, you take care of the healthcare, we look at the outcomes. Is that something, Dr. Gupta, you would think would work in India, because they are holding accountability for the money that you pay to a service provider and say, you are in charge of this segment of the population, you are responsible for the healthcare outcomes. Is that something you think should work?
I think we need to think of some alternate models of care. What we are talking about, say, any corporate hospital or say a big hospital, but the issues with the rural populations
it can be
very
government
different.
hospital as well.
Right.
It can be government.
So there is a possibility to try out such models.
Okay.
That you give the, in fact, in primary health care model, when it was conceptualized in 1950 or so there was a geographic distribution area and the population of that area and the set of government professionals and auxiliaries were responsible for the health of the people there. But I think that has not, over a period of time, that has really not worked. So I think it has to be linked with remuneration. Finally, it comes down why I should do this for the people. So if you give me, I'm not very sure about what works in UK, but a GP has a population or families to cover, and he is responsible for that, and he takes full care, and then he also buys services for the people, and also then this NHS also buys services from the private sector to make it available. So I think we need to really think, and what he was saying, Daljitji was saying earlier, why not to go for insurance and give risk protection to people if that works. So maybe this management of population and their health is very, very important. Now, shall it be done by the private sector, or shall the government sector do, or some other cadre or some mechanism is developed? That has to be really thought about, and at this point of time, to come out with such a model is not that easy. But we have models from other countries. And in our own countries, many innovations have been done. Many NGOs have tried many innovations of healthcare delivery. I think we need to test them, and we need to scale them up and see how these work. So we have to really look at such models.
Should we be reinventing the wheel is my question, because I think in our country there are some areas where the delivery of healthcare system has been far better than some other parts of the country. If there is a replicable model that has worked successful, we all talk about Tamil Nadu, right? If it is there, can we just pick up some of those models and replicate it rather than re-engineering the whole stuff? Because my worry is that there is so much of intellectual bandwidth that is already captured in all these reports. I think it is time for us to execute, and try some of the successful models that we have tried either in Tamil Nadu or in Andhra Pradesh, and try and replicate it maybe in a few other states to see how successful they are, and then move on. Those models can be modified as we progress as a society. If we are looking at the perfect picture to emerge, I don't think we will be just stuck where we are, and that should not happen.
So it's multiple models that would.
It's multiple models. It will never be. And similarly, it's a question of, is it only private? It is only public? No. We need to have a society where both private and public sector has got enough and more to play to address the healthcare challenge in this country, right? And also, I'm digressing, but probably what also bothers me a little bit is, whenever we talk about this healthcare, most of the time our concentration and focus is on affordability, right? And what we forget is the other aspects that we need to address in accessibility. Okay, first of all, is there infrastructure? Number two, is the treatment that is being given acceptable? Number 3, is there awareness of the disease? You know, you alluded, Rajendra or Dr. Agarwal said, dengue and malaria, or two of them he took as an example. He said, you know what, the patient comes to me and tells me that I am aware, and the patient is more aware of it than the doctor. Why did that happen? Because in a very systematic, concerted fashion, the government took upon itself to spread the awareness of this particular challenge. The moment that awareness became, I think the society learned about it and have taken precautionary measures, and probably we are trying to contain it to the extent possible. Awareness is such an important part. We are stuck with only affordability. Look at all aspects that are there to address the challenge of healthcare in this country, and just only focusing on affordability. In fact, it's in my opinion, if we address all these things, affordability, I think we can take care of the challenge. I don't think we are so under-resourced. We can address it. We did a very interesting study in Punjab, and this is what came to us as a surprise. Hepatitis C is a major challenge in Punjab, right? And when we went as to what is the exact problem, there is a huge set of non-economic barriers, and there is some set of economic barriers. But if you look at why today less than 1% of the patient population goes and takes a treatment for hepatitis C, it's mostly because of the non-economic barriers and not because of the economic barriers. We are focusing only on the economic barriers, forgetting the non-economic barriers, the myths, the misconceptions, the misunderstanding, lack of awareness. Let's address that. I think we will be able to address the healthcare challenge in a far more comprehensive manner if we look at every one of those dots, rather than just focusing on only the affordability part. I think India has enough money, and as I said earlier, if we have the will, the skill, finance is there, we can change the course of the healthcare in this country.
So I think your question was more around capitation and population health. My personal view is that today, if we look at the model of healthcare, we all call ourselves healthcare delivery organizations. We actually don't deliver healthcare. We look after, we are managers of disease, we are managers of problems that have arisen, health problems that have arisen, and we try and fix that when the accident has taken place, when somebody's had an heart attack, or he's come for a health checkup, and then we try and put him on good maintenance. I believe the future will necessarily need to move and evolve towards being responsible for people's health. I think if we have to call ourselves as a country or a system that manages people's health, then we've got to look at health in a very holistic manner. And therefore, for a given population, whatever be the affordable premium for that, probably something that will come to the hospitals or the doctors, and they'll be told that your accountability is to make sure that this set of people, they lead a healthy life. And I think then the entire focus of medical practitioners, hospitals, everything will focus to something very different. It'll be more proactive. It's almost like a coach, like a health coach. So I, as a doctor, would probably proactively segment the population of people, into high risk, into low risk, into healthy, not healthy, etc. And I would have strategies to make sure that the healthy remain healthy, that the people who are in the danger zone become, their lifestyle modifications take place to become even healthier, and those who are really sick, I'll monitor them like hell because I don't want them to come to the hospital. And therefore, my hospital simply becomes a focus area for me to keep my costs down. Because the more I keep people healthy, the more I make and the more I save. I think as a principle, that's a great principle to go towards, but it requires, I think, our entire society, entire system to evolve to a level where some of these experiments can be tried in limited geographies. And I think some of these models are being tried out by Kaiser Permanente and healthcare partners, etc., in the US, and their entire focus is very different.
So you made a very interesting point. As long as people participate in the entire ecosystem of health, which means what KG said, that you need to get them aware of what health is.
Absolutely right.
And once they participate, and you are responsible for an outcome of a population, which is population health. I think you were the one who brought this word out. I think that's the way the places where they've tried this, you actually ensure more accountable care for the money you spend. Shona, your views?
I totally agree with Daljit with this thing, and I think that if you're going to put a capitation model, let it be not treat them when they're sick, but keep them well, and then the whole model changes. That you'll start doing early interventions. So what Daljit explained was perfect. The only thing that I want to add a rider on all of you talking about these systems, when you democratize health to such an extent and capitate it, are we leaving this thing that no one is incentivized for excellence, for that innovation, for doing cutting edge, all that? You know, you're really not going to get, like I said, the 22 organ transplants that with that success rate, you're not going to do it. Everyone is going to look at, you know, at cost. And so I think that keep a rider. So you do need different models.
Great. So the difference between a fee-for-service model and capitation model is who takes the risks. So in a capitation model, you're shifting the risk to the provider, and in the fee-for-service, the payer is the one who takes the risk. So and both are not ideal. So typically, what happens is when you have a capitation model, you try to course correct by adding elements of fee-for-service to it, and vice versa. So if you look at the NHS, for example, the capitation model is how they pay the GPs. That's how every GP, as you were saying earlier, has a registry of patients, and each patient, they get money for each patient registered on the registry. But they have added to that, the risk of capitation is under provision of care and so on. So they have added to that this QOF framework, which is a quality outcomes framework, where they pay the doctor in addition to the capitation some additional amount of money for performance on some of the public health things. So either system has some flaws, but this one can be corrected by adding some elements of performance to it. I think it has great potential. I'm happy to hear people talk about Kaiser Permanente. One of the things we are going to try to do is to try some experiment in India with this kind of Kaiser Permanente kind of model as well, which has elements of capitation, elements of integration of care as well.
Thank you. I think this is a very interesting perspective, is to look at health management organization perspective to make it health more accountable. Now that our Honorable Minister has arrived, I think we'll take a political break for him to do the formal launch. It will be an exciting, we have many things to talk about, but I think time is short at hand. I thank all my panelists here for sharing their views, adding value to our discussion, and I hope this input will make it to the ministry and hopefully will actively acted upon. Thanks so much.
Thank you.
Thanks.
Thank you.
I would like to call on stage our chief guest for the evening, Honorable Minister Shri Shripad Naik, Union Minister of State, Ministry of Health and Family Welfare, to launch the website and address the gathering.
Yeah. Okay. Just press here. No. The guest present for today's function, Mr. Daljit Singh Ji, President, Fortis Healthcare, Madam Shobana Kamini Ji, Executive Chairperson, Apollo Hospital, Sri K.G. Anantakrishnan Ji, Vice President and MD, MSD India, Dr. K.K. Agrawal, Secretary General, IMA, Sri Girindra Bihari Ji, India Country Director, Bill and Melinda Gates Foundation, Sri S.D. Gupta Ji, President, IIM HMR University, Sri Rajendra Pratap Gupta Ji, Public Policy Experts, brothers and sisters. I am happy to be here with you today at the launch of ETHealthWorld.com. I congratulate the Economic Times for having the foresight to create such a platform where all stakeholders can dialogue, analysis, and discuss issues concerning the healthcare and related subjects. The launch of this newscaster is timely. It coincides with many new and challenging things happening in the sector. I am sure it will act as a force multiplier in our efforts to provide the health care to all. There could be no disagreement that it is necessary to optimally harness the public resources and technologies innovations to effectively management the growing burden of the disease, bridge the crucial skill gaps in the sector, and reduce the cost of care for providing better access for affordable health services. The new platform made by Economic Times will go a long way to realizing all this and more, positively influencing the pace and direction of the technological innovation in the healthcare are traditionally seen as a key enablers for the better healthcare delivery. Media, such as the proposed newscaster, can play a critical role in this. India is a country of diversities. The efforts of the governments has been to reach undeserved population through widespread use of different techniques. This includes centralized all center-based dial 108 or 102 ambulance network, use of over 18,000 ambulances for providing timely emergency care and helping pregnant women access institutional care for deliveries, allowing local level context specific planning, etc. Mobile medical units for tribal areas, board clinics in the riverine island of Assam, and telemedicine in states such as Tripura, Punjab, and Odisha. Widespread mobile devices penetrating has enabled the use of this mHealthCare platform for capacity building of frontline health workers and for data collection. This services use technology that is the handset independent, audio based, and assessed via a simple voice call to train ASHAs and NMS to deliver the life-saving information to the millions of families. This services also deliver timely sensitive audio information about the maternal and child health care for the mobile phones of the pregnant women, mothers of young children, and their families. Ensuring the universal access to the drug and diagnostic is a key priority of our policy. The pharmaceutical industry is one of the most vibrant sectors of Indian economy. It is the third largest in the world by volume and 10th in terms of value. The total size of the Indian pharmaceutical industry is about rupees 2 lakh crores. Increasing the cost of healthcare the world over has impacted the health budgets of many countries. This, coupled with the fact that the more and more medicines will be going off patent in the next few years, offers a unique opportunity to increase the soft power of our pharma sector. Drugs innovation and new drugs discovery are therefore important aspects of the SS, and government's policy would be to stimulate the innovation and new drug discovery to meet the health needs, as well as ensure that the new drug discovered and brought into the markets are affordable to those who need them the most. To ensure the seamless regulatory support, the Drug and Cosmetic Act is proposed to amended. This will minimize the hurdles and will take us closer to the minimum government and maximum governance, as emphasized by our Prime Minister Narendra Bhai Modi. Our indigenous system of medicine, which are otherwise less intrusive, offer a very effective and sustainable alternative for the disease prevention and control need popularization. For effective marketing of these therapies, there is also a need for adoption of the science and evidence-based approach. Ladies and gentlemen, we are living in an age of information overloaded with which can be overwhelm us, cloud our judgment and make decision making difficult. In sensitive areas like healthcare, this is even the more worrisome, and therefore there is a need for credible guide which filter and provides accurate information in an organized manner. ETHealthWorld.com has a role to play here, being that credible sources for healthcare industry and be the agent of change. I wish all the best to you all in this noble endeavor. Jai Hind. Thank you very much.
I would like to call upon Ms. Soma Das from the Economic Times editorial team to present the vote of thanks.
Thank you. Ladies and gentlemen, it's time to bring this brief event to a close. But the end of this event marks the beginning of a journey for ETHealthWorld.com. And we thank you for your good wishes and encouragement and hope that you will remain involved in different ways with this initiative of the Economic Times. On behalf of the Economic Times, and especially the team of the young and promising debutant in healthcare fraternity, ETHealthWorld.com, I express our deep gratitude to the Union Minister, Shri Shripad Naik. Thank you, sir, for your inspiring words. And ETHealthWorld will surely strive to become that one authoritative, credible source in healthcare sector, as you rightly said, in the age of information overload. We are very grateful to the dignitaries on dais, Ms. Shobna Kamaneni of Apollo, Dr. K.K. Agarwal of Indian Medical Association, Mr. Daljit Singh from Fortis, Mr. K.G. Ananthakrishnan from MSD, Mr. Gurindra Bihari from Bill and Melinda Gates Foundation, and Dr. Gupta. A big thanks to our moderator, Mr. Rajendra Pratap Gupta. We convey our deep appreciation to our partners, Nat Health, IMA, PHFI, and others. We must acknowledge the great support of about 50,000 pre-launch subscribers who are giving us constant feedback to help and make our platform better. Again, a big thank you to all of you who are present here in person to celebrate this occasion, and a big thank you to the thousands who have logged in, who are present with us and are watching the live webcast of this on ETHealthWorld.com. Finally, a special thanks to GE, who has reposed faith in our initiative much before the launch was even planned.